Good morning, everyone, and welcome back to Riverside Talk. My name is Denise Mananis. I am the Assistant Vice President for External Affairs at St. John's Riverside Hospital. Today, we are going to be discussing happy feet, good foot health. So before we begin, I would like to take this moment to thank my team, Jason Latour, Nancy Anabi, and Candace Cousins-Hopkins, who do all the work to make these things possible. I would also like to talk about our partners. We started this series of webinars with two community partners, Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library, and they have been very instrumental in helping us spread the word and getting information out to the community for us. But also this year, through the efforts of Nancy and Abby, we have been able to broaden our scope, and we welcome the Ashling Irish Community and Cultural Center, the Department of Veterans Services of the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, the Bronxville Community Center, the City of Yonkers, the Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. So welcome to all of these wonderful community organizations who are helping us get information out to the community. Now, before I introduce our speaker, I would very much like to encourage anyone in our audience who would like to ask a question to feel free to put it into our Q&A. And at the end of the program, after we've gone through all of the discussion, if we haven't answered those questions, I will be very happy to ask them. And so now it gives me great pleasure to introduce our speaker today, Dr. Berdj Stepanian. And let me tell you a little bit about him. Dr. Stepanian has been in private practice since 1993, specializing in medicine and reconstructive foot surgery. He is currently podiatric medical director at St. John's Riverside Hospital in Yonkers. That's us. So if you don't know, we're also in Dobbs Ferry. He is also on the staff of our Wound Healing Center, which is in the Andrews Pavilion at St. John's. Dr. Stepanian has been board certified by the American Board of Podiatric Surgery since 1995 and recertified in 2005 and 2015. He has been a diplomat of the American Board of Podiatric Surgery since 1995. In 2003, Dr. Stepanian has also become board certified in, I'm going to say this wrong, in pedorthotics or pedorthics. Pedorthics, okay. In 2017, Dr. Stepanian became certified by the Undersea and Hyperbaric Medical Society for hyperbaric oxygen therapy. He trained in the Bronx at Our Lady of Mercy Medical Center and served as chief resident in his second year. To date, he has trained over 150 residents. Dr. Stepanian graduated surgical residency in 1993 from the New York College of Podiatric Medicine and affiliated hospitals. And so right now, I would like to welcome Dr. Stepanian to our program. And so welcome aboard.
Good morning.
Good morning. So I'm going to just jump in, and I'm going to start with this topic, and it sort of has two roles here. One is aging feet, and then there's a side topic of diabetic feet, because I think that is a special category. So let's start with the first topic. When you're getting older, what are the most common foot problems experienced by the general population versus what people with diabetes should be looking for?
So both populations pretty much have the same foot problems. The diabetic part of it, and I'll get to that next. But as you get older, it's kind of like tires on a car. Your feet are being used, abused. We wear bad shoes. We walk on tough surfaces, and some of us really neglect our feet. And that in the general population will cause pain, and most patients will do something about it, either on their own, which we call bathroom surgery, or they will go see a professional, and say, hey, what's going on, and figure that out. The problem with the diabetic patient is that if they're uncontrolled diabetics, not diabetics who are taking care of themselves, they typically develop neuropathy, which is a loss of sensation. So, for example, on a person who doesn't have diabetes, they may have a corn, it causes pain. They're going to do something about it, either change their shoes or see a podiatrist. Whereas the diabetic may not feel that pain and they think that that's normal. So what ends up happening is that corn actually erodes and it becomes an ulcer, becomes a wound. And that's when the problems start. And that's any of the bony prominences, the bunions, the hammer toes, the spurs. They don't have that sensation.
Okay.
The added part to that, and this is important, is their circulation is affected as well if they're not controlled properly.
Okay. So you mentioned a number of issues. What really causes some of those? I mean, I know people who've had plantar fasciitis. I know people who have had corns. I know people who are developing bunions. So what are the causes of those, and what can people do to kind of make sure that they're staying on top of good, healthy feet?
So the number one thing that we all have is genetics, right? There's a predisposition for some patients to have certain foot problems compared to others. But after the genetics, it's usually what are we doing to our feet? And what type of shoes do we like to wear? Typically, women like to wear tighter things, high heels. Those promote bunions, hammer toes, and it also promotes plantar fasciitis because when you're in a heel, your arch is supported pretty well. But as soon as you come out of the heel, there's a lot of pain in the plantar fascia. And that's why most patients who have plantar fasciitis will complain about pain in the morning when they first get up. They walk a little bit, feels a little better, but anytime they rest, the same issue happens. So shoe gear is a major factor. Genetics is a major factor. Diabetes, because the loss of sensation and circulation, that's another factor. But the ones that we can control are basically our shoe gear and having our feet checked regularly by someone who does that, like a podiatrist.
Okay, so what causes a corn?
So a corn is rubbing against the skin on a bony prominence. So if you can see my hand here, if this is my fifth toe, this rubs against, and typically this is the first toe we see the hammer toes in. It rubs against the shoe. Your body, to protect itself, builds a corn. However, when the corn gets too big, it's like having a pebble in your shoe, and it hurts. And at that point, people do a lot of things. Sometimes they'll try to cut the corn themselves. They'll buy medicated corn pads and burn themselves. So that's when I talk about bathroom surgery. It's better that you go to somebody that deals with that. And people do go for pedicures, which is fine as long as the pedicurist knows what they're doing and you're bringing your own instruments. Now, if you're diabetic, I would strongly suggest you don't do that, that you see a podiatrist, let them take care of it properly, because that's where the problems start, when you start to do things yourself with diabetes.
Okay. Let's go back to bunions for a second. So you said shoes are a major cause of development of bunions. So high heels or any shoes.
Yeah, so what ends up happening, and I have a little model here, I don't know if you can see it. When you have high heels, the front of your foot gets compressed like this, which makes this bone right here kind of stick out. And that's the bunion area right here.
Okay.
So when that happens, the rubbing, again, there's a nerve that runs across here, gets irritated. People complain of numbness and tingling and pain right in this area. So this has to be accommodated either by wearing more sensible shoes, not so fashionable, or reducing the bunion deformity by surgery is really the only other way. Or I tell patients sometimes jokingly, move to a tropical island, never wear shoes, and you won't have pain anymore. But that's usually not possible.
So what you're saying is there's no exercise. I mean, for plantar fasciitis, I know that you can do some exercises and there's ways to sort of elongate the tendons in the back of the foot. There's nothing you can do for bunions once they start that development other than change your shoes. There's no exercise. There's nothing like that.
There is no exercise because the bunion deformity is basically a bone deformity. So there's nothing to reverse that displacement. Now, sometimes people will put a toe separator between their toes and that may buy them some time. But the longer you live, it progresses, and eventually, if you're either not wearing large shoes or orthopedic shoes, and you want to continue to wear fashionable shoes, you're going to have some type of procedure to correct that.
Okay, so you started talking about all of the things that happen to us as we get older, but are there things that people can be doing in their lifetime to keep their feet healthy over, sort of their middle-aged years, and lessen the impact? I know you're going to say sensible shoes, but that's a touchy subject, right? So
Yes, very touchy.
It's a very touchy subject. So are there, feet exercises to maintain your arch, your heels, flexibility, keep your feet, healthy in that way?
So there are exercises, but usually the general population that doesn't have any disease doesn't really do them because they don't have an issue, so they don't really care about doing that.
Until they wake up one day.
Correct, and then it becomes an issue. And there's really no way to strengthen the plantar fascia. That's not a muscle. It's not something we can work on. It's a ligament that attaches the heel to the toes, and anything that flattens that out, it could include gaining excessive weight. It could be walking barefoot many hours throughout the day, flip-flops, Crocs. Those type of shoes, we tend to see the promotion of that kind of pathology. So things that people can do, and you mentioned it, but the best thing we can do as people walking on hard surfaces is to wear sneakers. I'm a big proponent of sneakers. Now, I know that's not practical in some settings, but when you're doing your daily activities, you should be wearing a good pair of comfortable sneakers, preferably lace up. If you can't tie your laces, then Velcro, and never really use a slip-on, even though as we get older, we want to have slip-on things because it's easier for us.
Is that because there's no support in a slip-on, that it begins to stretch and it doesn't hold the foot in place?
Correct. Most slip-ons, and when a patient comes into my office with a slip-on, I will actually take the shoe and bend it myself with my hand, and then tell them, look, this is about 5 pounds of pressure. You're at least 100 pounds, 200 pounds, and you're expecting this to support your foot properly. It's just not going to be able to do it.
Okay. So there's 2 parts to this next question. What is gout?
So go ahead, sorry.
That's okay. And how do you differentiate between gout and arthritis in your feet? Because I know gout does tend to start in your feet.
So gout is an arthritic condition. If you like, it's part of one of even bunions are arthritic conditions as well. So the reason people get gout is because of uric acid. Now, uric acid develops in your body from eating proteins. So today we see a lot of it because people are on Atkins diets, they're low carbs, and either your body is what we call an under-excreter, which means you don't get rid of it quickly enough because you're not drinking enough fluids, or your kidneys are not properly functioning, or you're an overproducer because you're eating too many things. And typically, we'll see a gout patient after they've been to a wedding, after they've been to a party, and they've had alcohol. There's obviously the proteins, beef, chicken, usually shrimp. We'll see the flare up, and they'll come in and they'll complain of a red hot swollen joint. And 50% of the time it's in the big toe, but it can happen anywhere in the body in any joint. So to differentiate it from arthritis, it would have to be a patient that's chronically gout infected, because you'll see bitten appearance in the joint. The joint looks like it's been chewed on and it's eroded. Whereas someone who's doing it for the first time, they're going to come in, their joint's going to look great, but they're going to have this flare up. So it's really a diagnosis of exclusion. And we'll do blood tests to make sure they don't have an infection. And the uric acid will check after we get rid of the flare up, because usually when a patient is having the attack, a blood test is going to be normal. It's when they're not having the attack that the blood test will be abnormal, because the uric acid's already in the skin. It's come out of the blood.
Okay. And just to complicate this, is this an issue for patients with diabetes?
So it can become an issue, but they don't usually complain about the pain. So what happens with them is they'll just let the joint erode, and then they might develop a bunion or some kind of prominence. Then that creates the wound, and that's what ends up happening with them.
Okay. So I know that you see patients in the wound healing center, and oftentimes you're getting them when they have already gotten the wound. They've already gone down this road. Much of the issue, and you referenced the neuropathy in the feet, is that's a nerve issue, but is that tied to the circulation? And are there things that patients and folks out in the community can do to boost their circulation using supplements or other things that can help improve their foot health?
So the first thing is, before you take any supplement, ask your doctor. And the reason for that is because a lot of these supplements out there, they're not FDA regulated. They may interact with the medications you're currently on and create a new problem for you. There are a few out there that people like to use. We call the vasodilators like omega-3, beetroot powder, L-arginine, vitamin B3. Those are all things that they say might help with circulation. Turmeric, a lot of people are using turmeric today because it has curcumin in it to help with that. But there is really no definitive study that says, hey, if you take this, everything's going to be great. So we try to get patients to see their vascular surgeon if they're having circulation problems. We do tests in the office called ABIs to measure how much blood flow they have in their feet. And with the neuropathy, the key to the neuropathy being avoided is to keep very good control of your hemoglobin A1C, which we like to see below 8, preferably 7. And that's the blood test that we do every 3 months on a diabetic to see where they are. So when I have a patient come into my office, the first thing I ask them is, do you know what your hemoglobin A1C is? And the typical response is, my doctor said it's fine. And that, to me, the patient's really not engaged in their care, and those are the people that tend to have complications. Today, we're lucky because they have these new meters that a patient can put on, and they can see what their sugar is doing every day, after a meal, before a meal, and it gives them a little better control. So for diabetics, the most important thing is to control your sugar, don't smoke, healthy diet, obviously, and wear proper shoe gear, and have your foot evaluated by a podiatrist at least once a year.
Okay. So just some a little bit side topics here, but ingrown toenails. And I know a lot of people, especially like if I think back to my grandmother, as they got old, their toenails changed, and she started experiencing ingrown nails. Is there a way to keep your nails, more youthful and also correct, ingrown, the ability for these things to become ingrown?
So what we see in the elderly population, because sometimes their hygiene drops off because they can't really get to their feet. That's one of the things that will start a fungal infection. And probably in your grandmother's situation, she developed a fungal infection. The nails get thick, and what ends up happening is the shoes press the nails into the toes, and they end up getting ingrown toenails. So the first part of that is to treat the fungus, get those nails thinned out, and that will help with the ingrown toenails. But in the younger population, ingrown toenails are usually caused by the patient themselves, cutting their own toenails, cutting into the corners, going for pedicures and having inexperienced people do that, and doing bathroom surgery. Most patients won't go to a doctor. They'll keep trying to dig it out themselves. And when it gets red, puffy, and infected, they'll show up and go, hey, I've had this for a month. Can you save me? And that's usually the conversation. The only other time that we look elsewhere is we'll do an x-ray if the patient gets chronic ingrown toenails, because sometimes there's a bone spur under the nail that's pushing up on it and making the corners dig into the side. So that's what we rule out when they come in.
So what's a bone spur, and how do you stop those from?
Well, bone spurs are usually caused by trauma or a tumor. And if you can see the model, usually the big toenail is the one ingrown. Right here at the tip, you'll see that you'll have a little point that will grow, and that will push up into the nail.
Okay.
So the surgery for that is we actually remove that, and now the nail flattens out. The only other time you would see that is if there's a bone tumor, and that is a possibility. Doing this for about 30 years, I've seen about 5 of them come through the skin into the nail, and they were tumors, but benign tumors. They're removed and everything works out fine usually.
Interesting. Okay. So you mentioned this earlier, shoe selection, and you are, as I said earlier, board certified in pedorthics. Pedorthics?
Correct.
Is that how you-
Pedorthics. Yeah.
Okay.
It's
Yay
a
for
fancy way
me.
of saying I know what kind of shoes you should be wearing.
Okay. So can you talk a little bit about, footwear selection for people and orthotics and all of that?
So orthotics, and obviously I'm biased because I'm a podiatrist, but I think everybody should have a foot exam, and if your foot needs support, you should get a good pair of orthotics. The problem is that they're expensive if your insurance doesn't cover them, and most people will do fine with an over-the-counter type device as long as they don't have a real pathology. It's just more for support because we're not really built to walk on these hard surfaces. And when we're doing this for a long time and wearing the wrong shoes, that's when the problems start. So as far as shoe gear, like I said before, I think everybody should wear sneakers all the time. It's the best thing for your feet. Obviously not practical. Most women would go bananas if I said that's all you can wear. But the bottom line is fashion and function usually don't come together too well. So sneakers for your daily activities. I tell people who go to work and have to wear shoes, bring your shoes with you, wear your sneakers to the job. When you're in the car, change into your heels, go to your job, and then when you come back out, change from your heels back into your sneakers so that you're more comfortable and you're not causing any damage to your toes.
So is gravity and the surfaces that we're walking on, part of, I know someone whose arches have begun to drop. What causes that?
So there's multiple causes, but usually the main cause is being overweight, right? And you're asking your feet to do so much. We take at least 10,000 steps a day. Depending on what you do for a living, that may be more, that may be less. But the problem is obesity or being overweight is going to cause everything to work so much harder. And that's where an orthotic would come in to support your foot so that you can get through the day without all that trauma.
Okay. So I want to take this a little bit further into the sneaker discussion because there's a zillion and they all claim good support. And I don't really want to talk about brands so much as I want to talk about how do you know what you need to buy, what you need to spend, because my kids are buying $150 sneakers. When I was growing up, it was $12 Keds. So I'm confused and I look at a lot of things and they look good, but I don't know if those are the right things to be buying.
So by design, that's by design, right?
I know.
Because, bottom line is that they're marketing and things that look good but don't really function well, people will spend money on. As far as price is concerned, there's really no set price, but you can get a very good functional sneaker between $50 and $100 that's going to last you 3 months. Now, why do I say 3 months? Most sneakers, if you're using them every day, really have a lifetime of about 3 months. And the reason for that is because the air inside the soles, as time goes on, wears out. So they look good, they may be clean, but their support and their control has loosened up from time.
Oh, that's quite interesting. I had no idea you had to replace your sneakers that frequently. Well, that's good news.
So now your kids are excited, right? They can buy.
Yeah, no, I'm not excited about replacing my kids' sneakers.
The other thing is, if you look at the inside of a sneaker, when you take out the insole,
yeah,
on the better made shoes, you'll see stitching. You'll see almost like it's sewn. The cheaper shoes, the ones that don't give you as much support, are glued, so there's no stitching in there. And that's a good way of looking at it.
So actually, someone in our audience wrote a question in, and I want to ask now about the fit of your foot in the sneaker. And the question has to do with calluses and how they develop, and then how do you treat those?
So number one, the fit is very important, but most people today will buy their sneakers online. They'll go to an outlet store, they'll go to a Costco, and they'll buy their sneakers. What I tell patients is, first thing is go get fit properly at a sit and fit store. That's someone who will come out, measure your foot properly, give you the right shoe or sneaker, and that will lessen the amount of calluses that you develop. Calluses typically happen because things are not fitting properly, they don't have support, or you don't have any protective sensation against the callus. Because if you don't have diabetes, typically you'll feel, oh, you know what, this is bothering me, let me do something about it, and you'll decrease the risk of that callus becoming a problem. Whereas when you have diabetes, same thing with the description I gave you of the toe, that callus will then develop a wound underneath, and that's when the problems start for diabetics. So moisturizing your feet, well, diabetics twice a day should moisturize their feet as well as the regular population. Keeping them clean, keeping your nails cut properly, wearing socks. I see a lot of people today who don't wear socks. That's a major factor because that's not helping you with the friction inside your shoe, and that's going to promote calluses and corns, whereas if you had a sock on, that would protect some of that from happening.
So what's the difference between a callus and a corn?
Just the location. Calluses tend to be wider and on the bottom of the foot. We don't typically see corns on the bottom of the foot, and corns tend to be over joints, which you don't see on the bottom of the foot.
Okay, so going back to the callus for a second, the best way to treat those when you have one? So the best way
to treat, well, find out what's causing it, and usually it's pressure. There's too much pressure in the area, and that's where an orthotic would come into play. Because when we customize our devices, we customize them for places where you have excessive pressure. So typically we'll see a patient with a callus under the ball of the foot, maybe the second, maybe the third. So what we'll do is we'll make a device that will spread the weight more evenly over the front of the foot, so those calluses don't come up as quickly. And when they do, they're much less severe.
Okay, so I do have a question, and this is probably something we should have done earlier, but the question is neuropathy. What is it? And
so neuropathy is damage to your nerves, and that can be caused by alcoholism, it can be caused by diabetes, it can be caused by cancer treatment. So the bottom line, though, neuropathy is loss of sensation. And when it becomes loss of protective sensation, that's when it's dangerous. Pain is good because it lets you know there's something wrong. The problem with neuropathy is they can't feel it. So whatever's wrong continues to fester until it becomes a real problem. And that's where we get our wounds and our amputations and our osteomyelitis. So pain is good, but neuropathy, they don't have that ability.
So now that we're sort of going back down that road, can you talk a little bit about what you do for people who do have that neuropathy, have developed a wound of some sort, and you know, what's the line of defense? What's the attack, rather?
So the first line of defense is obviously not to get the neuropathy. And that's very possible if you control your diabetes, not to have it. Now, sometimes people have diabetes for years before they're diagnosed. And that's when the damage is being done. We've had patients come in full-blown infections, and then they realize they have diabetes, but they've had it probably for a couple of years. Alcoholism, obviously, that has its own caveats. That has to be managed properly. But alcoholic neuropathy is a thing. And neuropathy is usually not reversible. The problem is the damage to the nerve is done. We try to supplement sometimes so that maybe they can grow some more nerve tissue back. The problem is it takes so long for that to happen that in someone's lifetime, unless you're very young, that's probably not going to happen. So the key is not to get the neuropathy. But once you have it, now you have to have a podiatrist in your life because they need to manage you properly with orthotics, shoe gear, and your diabetes. It has to be managed properly. Your vascular status has to be managed properly. If you have a wound, nurses are very important because at home we have visiting nurse service. In the wound care center, the nurses are very integral to this process. So it's a team approach, infectious disease to help treat any infections. Diabetic wounds are very complicated to treat because there's so much going on in that patient that we have to monitor each one of those things to get you to optimal. And optimal is good circulation, pressure is relieved from the area, and offloading, staying off the area, which is not very possible for a lot of these elderly patients. So we have things like casts. The cast you can walk in, but it relieves the pressure from the bottom of your foot. It transfers it to your leg. It's called an offloading cast. And that's probably the most common thing we use today because patients can comply with that. It's all about compliance. Because I know people want to know how fast is it going to heal. We can't tell you that. It all depends on what you do when you leave us. We have you for about a half hour, 45 minutes every week. And then when you leave us, if you're smoking, if your diet is poor, and it just kind of throws the game off. So we can see wounds heal in 30 days, which is optimal. If your wound's taking longer than 30 days, you should probably be in some kind of wound care center being managed properly by all the specialties to make sure you help heal that.
So do you ever get to that point in these situations where you're doing surgery?
So sometimes if the bone's infected and the pressure area can't be relieved or the patient has gangrene, we know it's not going to come back. At that point, we give the patient options. And the options are we can take off a little piece, we can take off larger pieces. The reason is we want to give you a foot to walk on. So sometimes if you have 3 toes that are involved and now we're just leaving the first and second, these 2 toes are going to be a problem. So we usually recommend what's called a transmetatarsal amputation so that the shoe could be made for them with a filler and they can walk normally after that. So there are surgical procedures. We try to avoid them because they're usually devastating to the patient, but really you can walk without your toes. Your big toe is really the most important for balance, but you can walk without your toes.
So that's very interesting, and it sounds like that's kind of at the last resort for treatment. But there are the modalities that you were referencing and the different disciplines that work in wound healing. You have vascular, you have the nurses there, but what are the other treatments that you're using? I know that you have skin substitutes and those kinds of things. What are you?
So once we've evaluated their circulation, controlled their diabetes, their nutritional status is good, then we will consider using things like hyperbaric oxygen and skin substitutes. We don't usually get to those though until we can stabilize the patient and the infection because they won't work in those situations where you don't have blood supply and there is an active infection going on. Okay. So skin substitutes and hyperbaric today are a big part of our treatment plan. That's why a wound care center is usually the best place. If your wound is not healing in a private practice setting or whatever you're doing at home, you should have a consultation with a wound care specialist.
Okay, but for those aging adults who don't have diabetes and are not experiencing wounds, some of the things that you're talking about are preventive measures, because even when you get to be much older, you start seeing some of these problems from pressure and the things that are forming. Okay, so a couple of other questions that we have here. Athlete's foot. That seems to be something that comes and goes. What is it and how do you cure it?
So it's a fungal infection, and it usually happens because we put our feet in a dark, moist environment. Kind of like mushrooms, they like to grow in a dark, moist environment. That's what fungus is. And if you give it a dark, moist environment, sweaty feet, that will thrive. Typically happens in the warmer months because your feet sweat more. So this is kind of opening season for fungal infections for us. So we'll see a lot of the Tendinitis, which is typically the main culprit in this case. So I tell patients, Lysol your shower or bleach your shower because it lives there. Once that's done, it's gone. Take your shoes or sneakers, Lysol the inside, seal them in a bag for 24 hours to kill the fungus that's living in there. And then daily, change your socks halfway through the day, spray your feet with athlete foot spray powder, and that usually will keep you in control. Now, there are some patients, because of either thyroid issues or other medical issues, that sweat year-round, sweaty palms and feet. But once you manage the underlying disease, that kind of goes away.
Okay, that's very interesting. I have another question from our audience on tendinitis and how to manage tendinitis.
So tendinitis depends where it is. The simplest treatment is to take an anti-inflammatory medication, but there are patients that can't do that because it interacts with their other medications. So ice, elevate, rest, usually the mainstay. But those patients that complain about tendinitis, it's usually chronic. So they'll come into the office, we'll do an x-ray, we'll notice that there's a bony prominence that the tendon is laying over, and that's causing that tendinitis type feeling. And then we offer them treatment modalities. We can use lasers, we can use injections, we can use shockwave therapy, which is ultrasound delivered into the area. But and it also depends on, is the patient obese? Are they wearing proper shoe gear? What's their lifestyle? Do they run 30 miles a week, or are they sedentary, basically sitting at a desk? And that will guide your treatment as to how we're going to proceed.
So if you said you recommend icing, and I hear that for other kinds of, if I had tendinitis in my elbow, how long do you ice? And then how often over time do you keep your foot up? And, it seems very vague, but what's the real rest that you require? Because people are impatient. I know from myself, I don't really want to invest the amount of time, or can't invest the amount of time I need to stay off of something.
Right. So if it's an acute problem, using the ice, using the anti-inflammatories, and resting for a couple of days should take care of it. Usually these are chronic problems. And at that point, that's when you got to get a little more aggressive. And typically in our practice, patient will come in, we'll x-ray them, we'll talk to them about their lifestyle, we'll look at their shoe gear, and then we'll decide. And I usually will start with an injection. That usually gets them to about 50% within the first week. By the second week, on the second injection, 80%. By the third week, they're 100%. Now, let's address during that time, why did you get the tendinitis? Were you wearing the wrong shoes? Is there something under your tendon that's irritating it? It's usually something the patient's doing or not doing, like stretching. Stretching before you exercise, stretching after you exercise. Those are things that we don't really pay attention to because we don't have the time for it, like you said. However, very successful if you do it before, during, and after exercise to get that stretching in there. The Achilles tendon is typically where we see most of our tendinitises. And if you can get that to stretch, it's not going to hurt when you're doing your activities.
But most people don't know how to do it safely. They don't, even though it may occur to them to stretch or to do something. I mean, are there some simple things that they can learn, or where can they go to get information on how to stretch safely?
Yeah, there's plenty of places. One of the places for the foot, there's a place called creakyjoints.org. And if you go into the search engine and put in arthritis, they have about 7 different stretches for the foot. The one for the Achilles tendinitis area is usually stretching your calf. And calf stretching is important because, again, we want to lengthen that Achilles tendon with the stretch to take the pressure off the back of the heel and to avoid, it also helps with plantar fasciitis, because if you're not pulling on the heel, you're not pulling on the ligament on the bottom of the foot, and that helps alleviate the pain. And I will show a patient how to do it in my office, and I will also have them demonstrate it before they leave my office on how to do it. And you can Google calf stretching, and 90% of them are correct. But if you go to reliable sources like nyfoothealth.org, WebMD, look these things up. They're there. They're for your use, and they do work if you do them. But you have to be diligent about doing them.
Okay. So that actually brings me to my last question, which is sort of a general, and I think you were sort of going down this road right now, the general tips for keeping your feet happy and healthy. If you could just review or add to what you've already spoken about.
So wearing proper lace-up shoes or Velcro, that's number one. Keeping your feet clean, dry. The other thing that's very difficult to treat today, but many people have it, is fungal toenails. You should seek treatment for your fungal toenails, especially if you're diabetic, because your risk of amputation increases 2 or 3-fold when you have fungal toenails and diabetic neuropathy. Very important to be proactive. And the last thing is, if you have something that's hurting you, get it addressed, because the longer you wait, the harder it is for us as surgeons to fix it, because you've let the deformity become so debilitating. Whereas if you came in when it first started, we may not even have to do surgery. We can suggest something that'll avoid that surgery. So see your podiatrist, see your foot care specialist, and that's pretty much the best way to take care of it.
Thank you very much, Dr. Stepanian.
Thank you.
This was wonderful. We really appreciate your time. Before we close today, this is how you can reach Dr. Stepanian. He, as I said, is our podiatric medical director of Wound Healing Center. He does see patients here as well as in his own office, and he can be reached by calling 914-964-4630. Also, anyone out there who would still feel that they would like to see a physician through urgent care, virtual urgent care, rather than coming in, we are very happy to register you by calling 914-207-0006 and make an appointment for that virtual visit. And finally, if anyone has any questions about today's program, please feel free to send them to info@riversidehealth.org. That actually comes to me, and I will be happy to get those questions answered for you. And if you would like information on any of our physicians, physician referral, find a doc at riversidehealth.org. That email also comes to me, and I will make sure that that gets handled by our physician referral specialists. So we appreciate you being with us today. We look forward to seeing you again. Be on the lookout in your email inboxes for the next program that we're going to be running. I don't really remember what it is, but you know, we take your suggestions as well. So feel free to send me an email and give me some ideas for topics that you're interested in. And thank you again, Dr. Stepanian, and be well, everyone.
Thank you.